Welcome, everyone. Allow me to present my PhD topic, male infertility, functionality, and surgery. My name is Anett Szabó, and I work at the Andrology Center with Zsolt Kopa, and my vision is to educate patients regarding our findings on the risk factors impacting fertility, and my mission would be a larger scale education of the population. We have 4 projects in total. 2 of them are about sperm DNA fragmentation. One is on non-palpable testicular tumors, and the first one is an artificial intelligence-related topic. The first one is the risk factors associated with sperm DNA fragmentation. You have to know that infertility rate in developed countries is quite high, and sperm DNA fragmentation is known to impact fertility. There are several risk factors that may influence sperm DNA fragmentations, such as lifestyle factors, diet, obesity, and smoking, and so on. And our aim was to investigate the effect and extent of known and suspected risk factors on sperm DNA fragmentation. The clinical question was, what is the correlation between the different risk factors and sperm DNA fragmentation? For this, we examined every male that was included in the studies. We looked at different risk factors and compared it to the absence of the risk factor, and the outcome was the sperm DNA fragmentation. Our hypothesis was that there is a correlation between the studied risk factors and sperm DNA fragmentation. We started off with almost 27,000 articles, and we extracted data from more than 200 articles. So just a few words on sperm DNA fragmentation before we move on. It is the only evidence-based sperm functional test there is, but there are no exact cutoff points, and we can't differentiate based on sperm DNA fragmentation on whether a person is fertile or infertile. We prefer the value of sperm DNA fragmentation to be below 25%. Between 20 and 30%, we might expect adverse pregnancy outcomes, but between 25 and 50%, they're still eligible for in vitro fertilization treatments. We did subgroups based on the assay used for sperm DNA fragmentation measurements and also based on the fertility status of the males. These are all the risk factors that we looked at, and just to highlight the more clinically significant ones, one of them is varicocele, and when compared to the absence of varicocele, we see a difference in sperm DNA fragmentation of almost 14%. When comparing smokers to non-smokers, we see a difference in sperm DNA fragmentation of almost 10%. When comparing abnormal glucose tolerance with normal glucose tolerance, the difference is almost 14%. And when looking at the age, there is a bigger jump after the age of 50, with a difference of almost 13% in sperm DNA fragmentation. So as a conclusion, varicocele, abnormal glucose tolerance, smoking, and increased age certainly increase sperm DNA fragmentation, and some risk factors also show this dependency. Some of the strengths include that we looked at all the risk factors that have been studied so far. So we have a very high number of articles and also a high number of patients, but there are limitations. We have no longitudinal studies. We can't just look at a single risk factor because there are always others influencing it. We have only a low number of studies for certain risk factors, and we have a high heterogeneity in most of the cases. As an implication for practice, based on this knowledge, we can give specific suggestions for each patient on how they might modify their sperm DNA fragmentation. And as an implication for research, we would need more studies for certain risk factors, so an establishment of registries would be advised. So currently, we have submitted our manuscript, and from the third journal, we received positive comments, and currently we are answering these comments. The next topic is the efficacy of interventions aiming to improve sperm DNA fragmentation. The background is pretty much the same. As you have seen before, there are several risk factors, so we need to target each of them differently. Some of the potential interventions include exercising, cessation of smoking, and so on. And our aim was to investigate the interventions that could potentially decrease sperm DNA fragmentation and guide clinicians and patients towards the best interventions that we could apply. Our clinical question was, do lifestyle changes, medications, and other interventions aiming to increase male fertility decrease sperm DNA fragmentation? Our population was males, and we looked at any intervention that tried to improve sperm DNA fragmentation and compared it to the absence of the intervention or no intervention, and the outcome in every case was sperm DNA fragmentation. Currently, we have extracted data from the articles, but since the search was done over a year ago, we're going to rerun the search to be up to date with the articles. Here are some of the interventions that were looked at. The most common one that was looked at was varicocelectomy, antioxidants, antioxidants plus lifestyle modifications, and so on. The next project that we have is the prediction of sperm retrieval in non-obstructive azoospermia via an artificial intelligence software. Azoospermia is when there is no sperm in the ejaculate, and we divide it into two subgroups, obstructive and non-obstructive. Here we are only interested in the non-obstructive subgroup. There are several approaches which can be applied to retrieve sperm from the testes. One of them is a biopsy, another one is a multifocal biopsy, but the best one is the testicular sperm extraction. Currently, there are no means to predict whether we find sperm or not if we do the testicular sperm extraction. So our plan was to change this. Here are the parameters that we found to be of interest. One of them is total testosterone. This seemed to be the most significant one. Also AMH, AMH squared, and so on. So our hypothesis was success of sperm retrieval can be predicted via preoperative parameters, and the clinical implication would be to avoid unnecessary surgeries, select individuals most likely to benefit from the surgery. We started off with 91 patients, but as you might know, with these artificial intelligence programs, the more patients you have, the better results you expect. So we added more patients, and finally we had 174 patients in total. We have a logit model and a neural network, and the software is being retaught after every few patients. At the beginning, the accuracy of the predictions was between 65 to 70%, then it decreased, but with these 174 patients, we managed to increase it back to 65%. And we're also planning on involving more centers, both for cohort validation and also to increase our patient numbers. Currently, we have started writing the manuscript. We are writing the methods and the results part now. We have one more project, the non-palpable testicular masses and their testis-sparing surgeries. What you have to know about it is that non-palpable testicular tumors are usually benign, so that is the reason why we prefer sparing the testes. But we will go into more details with this one later on, because we're not currently concentrating on this project. So in total, we have four projects, and the first one was submitted, and the rest we are planning on submitting them next year. So thank you for your attention, and as a quote, today is the first day of the rest of your life. Make it worthwhile to continue. Thank you.
Actually, I'm just wondering, because nowadays everybody wants to make AI predictions in medicine, and what I see that, of course, we will have very nice predictions. However, how can we actually use them in the clinical practice? So you will find an AUC with 0.6 or whatever, how this will actually change sperm retrieval practice in these patients. And actually, regarding the first project, I just realized that, or maybe I was not paying attention when we were writing your study, that may it happen that actually that's why in certain cases we didn't find significant result, because there are other sperm quality related parameters that will influence whether the DFE, the DNA fragmentation index is higher or lower, or is it okay? Was it okay actually to analyze the general population regarding these risk factors? So shouldn't it be a very selected population where every other factors were included regarding infertility, and there are no actually reasons, and we see that there is a risk factor which may modify the DFA, if you understand what I want to...
I'm not really sure what you mean by the second question.
We were looking at general population
yes.
regarding risk factors, but we know that there are factors that, for example, certain quality factors that may influence fertility in males, which may be a reason or not for infertility, and not actually obesity behind. So, so let me rephrase the question.
For example, if they had some kind of an underlying condition which made them infertile.
I mean, we cannot conclude in this case that obesity is the reason, or obesity had an effect on a higher DFA. So I'm just saying that maybe there is a difference in the results, because I don't know whether they excluded other reasons of infertility or actual reasons of infertility in these cases.
Well, we always looked at the eligibility criteria, and I do think if there would have been an underlying condition that would have affected infertility so much, then they would have excluded that patient.
Maybe, yes. And
at least I hope so. And yes, and the other one, our aim with the artificial intelligence software is that if we add more patients, we hope that the accuracy will further increase. And if the accuracy is high enough for the predictions, we plan on doing this prediction before every single sperm retrieval, so we can tell the patient what his chances are that we will find sperm. It's still going to be his decision whether he wants the surgery or not. He will just have a more clear picture.
I would like to reflect to Szilárd's words that that's my problem as well with all those studies, you know, with the fertility and etc., which have a huge amount of factors influencing early childbirth or IUGR. That how can you answer these questions with meta-analysis without what Professor Hegyi has said, without very high quality data? Because if they don't report it, then you won't be able to adjust for all the 100 tons of kinds of variables. So you need good cohorts for this. Or on the other hand, if your population is high enough or big enough, then I may say with my statistical head that the differences may be a bit slightened or straightened as the population is increasing. So I don't know if you mean what I would like to say.
Well, I really do hope that they excluded those patients. We didn't see any indication that they would have included patients who had severe impairments regarding their fertility.
Do you plan to collect prospective data, or do you have something in the planning this regard?
For the artificial intelligence?
No, I mean the DNA fragmentation analysis and the cofactors.
For the DNA fragmentation, that was the reason why we didn't want a prospective study for that one, because we know that the quality won't be so good because we can't account for all the risk factors, and that's why we will focus on another prospective study rather. It would be interesting. It was my initial plan last year, but everyone was against it. So we decided on focusing on something else.